looking at maternal and newborn health. I think it's fairly appropriate to this conference, and just looking at some experiences and also some reflection on the role of a knowledge hub like this over the past few years of work. So it's really a snapshot, an overview of the work that we've done. And my section of it is focused on maternal and newborn care in difficult settings, high mortality settings that are characterised by certain features, I'll say. But from the outset, we've tried to adopt a systems perspective and matching the health systems framework of the other partners and the other knowledge hubs. So there's AusAID Knowledge Hub on health information, on human resources for health, on health policy and financing. So we started with that frame. And within that, for MCH, and this is something you hear coming out at almost every session that women deliver, we've been focused really firmly on the service delivery side of the health system. I think that's obviously a critical area for MCH. And we've been collating, essentially, because it's service delivery, implementation, research on interventions, within the packages of interventions, then how you deliver those packages. And we've looked at high mortality settings, and really those are places where a lot of births happen outside of health facilities, where access is difficult. And we call it settings, not countries, because we've aimed to look for solutions that are different for those settings within each country. And in particular, we've been examining what could be done at the community level at that most difficult time, which is the time of childbirth. So from shortly before labour starts to the first couple of days after the baby comes out. Other parts of the hub, particularly Kate's Centre for International Child Health, have looked at the health facility part of that spectrum and the quality of care issues. And if, as Ben said, if we're thinking about problems in the Asia-Pacific region that are more unique and more specific to that region, and you think about places like Vietnam and China that are so rapidly scaled up, health facility childbirth, quality of care is the critical issue to look at. So just flag that as one Asia-Pacific type of service delivery issue, but it's not the one I'm looking at. I'm looking at those women in remote villages who don't have access to services. And it started with a literature review in 2009. We were trying to look at the question of whether community-based care has a place in high mortality settings at the time of childbirth. And particularly in the atmosphere at that point of global policy saying the whole push has to be towards facility-based childbirth. If that's not happening, then you bend all your energies to make it happen. And that's the end of the strategic and policy story. And we're following the lead of some international people and our own experiences and saying there may be a second route. And we did some site analyses. Jenny Kerrison's here, she did one of those for us, of policy and practicing 4 sites that I've listed there. Turned that analysis of policy and practice into a policy brief. So you can see in this sequence, we started with a review of the evidence, but then tried to apply it to particular settings and their policy and practice needs. And that's been the pattern that we've worked in the hub. And when you analyse the evidence, there clearly are packages of care with potential for significant newborn and maternal survival impact. But they need to be introduced with caution, and they must be synchronised with health facility strengthening. So some of these packages, like the standard essential newborn care, facilitated referral, perhaps more adventurous, the delivery of oxytocics, even self-administered by the woman, if we think of misoprostol, antibiotics that could be delivered from trained workers, and in yesterday's session on postpartum care, it was confirmed again for me that all of the focus on delivery of antibiotics in the first few days after birth in the community is on providing antibiotics for newborns who are suspected as having infection. But we know at least 8%, maybe as much as 20% of maternal deaths in the worst places are related to infection. And there needs to be discussion about antibiotics for the mother delivered in the home where they're needed. So this policy and practice analysis, really this slide is just to show that if you contrast places by their MMR, you don't really get enough of a feel that if you do the more detailed analysis that we did, that's summarised in that middle column, you can come up with differences between settings. So it was clear from our analysis that Papua New Guinea and Laos were the two places where a really strong focus on community care could have a place at the time of childbirth. Whereas for the others, it was a much lower level supplement to first level health facility strengthening. And I think when you take global evidence, do a detailed site analysis and then apply it, this is the type of differentiation you can come up with. Also thinking about issues specific to the Asia Pacific region, this taps into another part of this same theme. If you look at the international evidence for community care, saving newborn lives in particular, which is where the evidence is strongest, 80% of it, 90% of it comes from South Asia. A small amount of it comes from Africa, but very little of it comes from outside South Asia or Africa. And one thing that our region, the Western Pacific region in WHO terms, has got that the other regions don't, is this experience with birth dose vaccination. Birth dose vaccination is trying to reach babies in the first 24 hours. It's the same critical time period we're looking at. And it's had a strong WHO-led strategic push around scaling up birth dose vaccination. And we also had our own past research done with PATH and others, and we'd shown previously in PNG that if you train a volunteer to use something like Uniject, you can actually reach 75% home births with both the vaccination and an integrated package of postnatal care. And having the hub behind us meant that this didn't stop as a small pilot study. It meant this is something that we could pursue and put some sustained effort into. And so we had one of the outcomes was the hub team really were funded by AusAID to contribute to the global evidence database by supporting WHO in producing this document, Practices to Improve Coverage of the Hepatitis B birth dose vaccine. And it meant because it was us doing it with the Western Pacific viewpoint, we were able to inject a much stronger message about integration of vaccination with postnatal care for the mother and the baby than would otherwise have been the case. We're also able to contribute to the provision of injections by lay health workers research with the Knowledge Centre that we're doing some work with WHO RHR. So if you wander the WHO stall, you can see this document there, which the hub has been able to contribute to. It's a fairly important piece that gives countries assurance that there are some things around maternal newborn care that is okay to do task shifting on, and here's the best collation of evidence for that. And with Jess and others, Kelly's sitting there, we've been working for the Western Pacific Regional Office Health Systems team, again on a similar theme. What is the evidence for the community actions that actually show a strong linkage right through to maternal and newborn outcomes, including survival? And I've mentioned already we've identified a gap around the management of sepsis in the mother after childbirth, and we've been able to pursue that with additional literature reviews and proposals for how to include addressing puerperal sepsis in implementation research. So the last story I'm going to tell is around policy and advocacy-oriented evidence reviews. So these are not systematic reviews that will end up in a peer-review journal, although you need to use rigorous methods that fit with that to do this. But these are reviews that start with putting the evidence together, but then really explicitly applying that evidence to the policy and practice needs of a particular setting. And in this case, it was in Papua New Guinea, and looking at what scaled up community care could do in that setting for improving maternal, newborn and child survival. And what was important was to not just start with the evidence, but look at the experience in PNG, match those two together, add some value for money judgment to see which of these approaches would make the difference. And not to stop with the policy report, but the targeted 2-page policy briefs that were tailored quite specifically to Australian and PNG policymakers, had clear action requests. I learned a lot from World Vision about sitting outside MPs' offices and what you have to do to make something happen. And we got quite a definitive response from the PNG government to say, yes, this is something we need to take more seriously. They held the first national conference on health volunteers last year as a response to this research. They've appointed a national coordinator who is looking at what are the correct roles and responsibilities, what should national policy say about this level, that many people have been calling for a long time. Many non-government organisations in PNG have been working on, but it took just a little bit of a catalyst that something like a knowledge platform can provide to help move it along one step. So again, in the sessions that I went to yesterday, it's clear that for maternal and newborn health in the most difficult settings, including those in Asia Pacific, there are some service delivery questions that remain. What the hub work has done for us too is to set up the implementation research agenda very firmly focused on our region that we can take forward by other means, such as philanthropic supported research grants that we have on the boil, as not as the hub necessarily, but as Burnet, one of the hub partners. And so this work has been able to help us make that agenda much more specific to our region. And these are the things I'm hearing around the halls here, which are similar conclusions that the hub research has led us to, that service delivery questions for the newborn continue to be around how do you get the timing of a home visit right, how do you get the balance of prevention and treatment, how do you do better at integrating with other programs. For the mothers, when we're talking about community care, we're often talking about a stopgap program that gives some extra work while we're building the health system for mothers to access it more comprehensively. And that raises questions of how to do it in a way that doesn't discourage facility-based delivery. And issues for both are really health system strengthening ones, integration such as family planning, and comprehensive primary health care. So we've had a regional knowledge platform supported by a development partner, that's AusAID, which enabled for the researchers among us a stronger focus on what does it take to apply your research to policy. And for the development staff among us, a stronger recognition of the role of just the implementation of evidence. Tailored work to address the sites in our region in some specific settings, and regional and global engagement. If the hub had not been here, that sustained work to contribute to WHO documents just wouldn't have been possible. It's not something researchers easily put time into. And it's forced us to engage with networks such as the Alliance for Health Systems and for Women Deliver as one. Thanks very much.
Chris, thanks. I've got a couple of questions. And so what we'll do, I'll ask a couple of questions, have quite a short response, and we'll leave some space at the end to open up to the audience. Chris, just a couple of reflections on how well we've done on integrating postnatal care for mothers and babies.
I'm embarrassed to try and answer this because Matthew's not on that section of WHO sitting up the back there.
He may want to comment.
No. Sorry.
But I mean, I think there are obvious points of integration between the two programs that are still not happening. And you still very often find newborn care programs and maternal health care programs that are funded separately, that are training different staff, and not that well coordinated. And I think one of the reasons why that happens is people think in disease silos, or they think in technical silos rather than from a service delivery point of view. And you know, if you think who is going to be there at that critical point, who's there delivering the baby and they're available for the mother and baby in those first few hours, who's there providing postnatal care, then that helps change the construct. I think there has been some progress. The fact that WHO is now defining postnatal care something that includes mother and baby. So it's not postpartum, there's not neonatal, there's one construct. I think that is quite helpful. I think there's been a lot of work at the policy level on the continuum of care. I think it still needs to roll out into programs. And for me, the emphasis on newborn sepsis but not on puerperal sepsis for the mother is just one manifestation of that.
I think from my side, it's about the practical issues, the nuts and bolts in a poor rural community when you've got maybe one health worker and not much actually access to resources. How do you actually make this happen, and how governments and donors support this in very practical terms? I think there's a challenge of translating the conceptual stuff into the delivery. So just to move on the your views on the trade-offs between investment in community services versus first-line primary care. Just sort of thoughts on that.
I think for maternal survival particularly, this is a really difficult paradox. How much effort do you put in strengthening first-line facilities to get mothers to have their baby there? How much effort do you accept some women are going to continue to have their baby at home? And can we make that safer for them? I think the limited evidence that's out there suggests that if you put effort into making a home birth safer, have the discussion with the mother before delivery or the family to say, have your baby at the facility, but if you don't, here's some things you can do. Generally, that doesn't encourage home birth. It seems to encourage more women to come to the facility. And for me, the practical application, though, is we should only invest in community care if at the same time we've got synchronised investments in first-line health facilities to strengthen those. And it worries me a lot when I see NGOs in Papua New Guinea who are working in such remote areas that they don't have the option to invest in the first-line health facilities, and all of their investment is only at community level. I think that's fine for, say, childhood malnutrition or under 5 pneumonia or something. It doesn't fit so well for delivery at the time of childbirth.
Right. Well, I think there'll be an opportunity for you to ask further questions later on.